Welcome to the workshop, CAR T-cell therapy for lymphoma. What's involved, potential outcomes. I'd like to thank Kite, a Gilead Company, whose support helped make this workshop possible. My name is Michaela O'Brien, and I will be your moderator for this workshop today. It's my pleasure to introduce today's speaker, Dr. Basem William. Dr. William is the Clinical Director of the Blood and Marrow Transplant and Cell Therapy Program, as well as the Medical Director of the Cell Therapy Laboratory and Immune Effector Cell Program, and an adjunct professor at The Ohio State University College of Medicine. Please join me in welcoming Dr. William.
Thank you so much. I'm grateful that I have the opportunity to speak with you today, and I'll try to walk you into the current status of the use of CAR T cells in the treatment of lymphoma. This is what I'm going to try to cover today. I'm going to cover the rationale. Why do we use CAR T therapy to treat patients with lymphoma? Who would be a candidate for CAR T therapy? What are the steps involved? What are the potential short and long-term risks? And also what are the potential outcomes? I'm not going to cover myeloma, but I'll allude to whichever is available in that space. So let's start by discussing what's CAR T. So CAR T stand for chimeric antigen receptor cells. And the idea behind that we take the patient's own immune cells, what we refer to as T, as in T lymphocytes, and we genetically engineer those with typically a virus, and that would make them able to target a specific marker on the top of cancer cells, and do that without that marker need to be processed and presented to the T cells, a process called antigen presentation, which typically many cancers will evade as a mechanism of survival. So those cells, when they come and encounter the antigen on the top of the cancer cell, they will start attacking without the need for that antigen to be processed or presented, and that's a major advantage. And the reason why that works when chemotherapy fails, because it kills cells in a mechanism different than chemotherapy. So with chemotherapy, some of the cancer cells develop a mechanism that they become resistant to chemotherapy. They modulate some of the genes that will make the cells die, and the cell become resistant to dying after causing DNA damage, which typically how most chemotherapy drugs work. This is different. This is a living cell that came from the patient that had been re-engineered to attack the cancer cells. And once it engages, it produces a substance that opens holes in the cancer cell, and the cancer cell dies through that mechanism without the need to have a cascade that's dependent on DNA damage. So who are candidates for CAR T therapy? A part of that is, and maybe that question might be better rephrased, who have access to CAR T therapy? We believe that a lot of patients will benefit from CAR T therapy, but this question specifically says what have been approved by the FDA, so patients have access to it, and means this have been vetted through clinical trials and have demonstrated evidence of efficacy and improved survival. So patients who have diffuse large B-cell lymphoma, which is a commonest type of aggressive, rapidly dividing B-cell lymphoma we deal with, who have relapsed after receiving 2 lines of therapy, including autologous transplant. And just to clarify, a line of therapy doesn't mean a cycle of therapy. Line means a specific regimen. So typically, patient will have something like R-CHOP, and maybe after that, they have another regimen like RICE or RGBP or an autologous transplant. So that makes 2 lines of therapy. Or if they have relapsed within the first year of therapy, like they get R-CHOP, and maybe that PET scan they get at the end of therapy shows progression already. That's typically what we refer to as primary refractory disease. Or they enter remission and 2 to 3 months later, they relapse. So these are also eligible to receive CAR T therapy. CAR T therapy is also available for patients who have follicular lymphomas after 2 lines of therapy, and patients who have mantle cell lymphoma after 1 line of therapy, patients who have B-cell acute lymphoblastic leukemia after 1 line of therapy. And I prepared those slides before the recent FDA approval, so I believe now patients with myeloma are eligible to receive CAR T after getting 2 lines of therapy. Previously, it used to be 4. So this nice slide kind of shows you the typical journey of a patient with diffuse large B-cell lymphoma. This accounts for most of the lymphomas we see in the Western world. So right now, with a modern treatment regimen, especially with the introduction of the antibody Rituxan or rituximab, about 60% of those patients could be cured. But 40% unfortunately don't, and they progress. And for those patients, they either are healthy enough to get transplant or CAR T, and this way they can be cured. We're specifically talking about autologous transplant using the patient's own stem cell, or they are not healthy enough to receive those therapies, and then they receive multiple second-line agents that could result in durable remission, but are typically not curative. And then we're going to talk about how we make CAR T cells. We typically have the patient sit on the blood bank or the pheresis machine. They typically would have a dialysis pipeline unless they have big large veins where they don't need that. And that draws their blood into the machine. And the machine has a large centrifuge. It's all an automated closed system that separates the blood. And the red cells are the heaviest. They stay at the bottom. The plasma is the lightest, stays at the top. And then the white cell form an interface between the red cells and the plasma. And that's sucked through the machine and in a bag, and that bag is shipped to the company, and the company introduces a virus inside the cell. And with that virus, it includes a genetic construct to make those CAR T cells. And then after that, those cells are frozen and shipped back to the center. And the center at that time would give the patient some chemotherapy to deplete their T cells, so those cells would work better and infuse them into the patient. This goes over the typical CAR T patient journey. And there are proposed timelines, and here these are highly variable depending on multiple factors, which had to do with the patient geographic location, how many centers they have access to, and how quickly they can get to a center and how busy that center is. So the first step is a referral to a CAR T treatment center, typically from a community oncology practice, and that really varies. And then after that, it takes a center about 10 to 21 days to get insurance approval. Production request means they submit a request to the company and secure a slot for manufacturing. Before they collect the patient T cells, they have to make sure that the company have a slot assigned where they're able to make the cells. And then the patient will typically have to undergo an evaluation by a physician experienced in the administration of such therapies, make sure they're healthy enough to receive that. And then there is about 1 to 2 weeks for the actual T cell collection. There's a step where they sit on the pheresis machine. It depends on how many slots are available in those pheresis machines. That varies according to how busy the center is. And then the other process, what we refer to as quote-unquote manufacturing. This is where the company would introduce a virus with a genetic transcript inside the cells to genetically modify them, and then grow them in a cocktail of agents we refer to as cytokines to make them grow and be more potent, and that can vary. It can be short as 10 days It can be long as 28 days. Sometimes, for whatever reasons, those cells may fail to grow, what we refer to as manufacturing failure. And in that situation, typically the company speaks with the clinician. If those cells are healthy enough to be of some value, some paperwork is filed, and the patient can still get access to the cell. Or if the cells deemed to be just not effective enough and are likely to fail, then the options would typically either to collect cells from the patient again, if that's an option, or the clinician can decide to abort the procedure and move on to something else. And while the patient is waiting, they can undergo what we refer to as bridging therapy, which means another chemotherapy, immunotherapy, or another agent to keep the lymphoma controlled while the cells are being manufactured. And then after that, after the cells arrive to a center in a container, the patient will undergo a low dose, what we refer to as lymphodepleting chemotherapy. That's usually a combination fludarabine and cyclophosphamide, Cytoxine. That's typically given as an outpatient over 3 days. And after that, the cells are thawed and infused into the patient. That could be done either as an outpatient or an inpatient, depending on how the program is set up, and depending on other factors that have to do with the patient overall health, the expected rate of complication based on the specific CAR-T product, and maybe perhaps the amount of lymphoma in the patient body. And then after that, patient will be monitored for at least 2 weeks, but up to 4 weeks. And typically the first week or 10 days may happen as inpatient, and then the rest will happen as an outpatient. The recommendation for most of the product that the patient needs to remain within a close proximity to the treatment center for at least 4 weeks after the cells are administered. Then after that, we're going to switch gear and talk about some of the early toxicities that we expect to see in the initial 4 weeks of receiving the cell. And we're going to cover those with some detail. The first one is called cytokine release syndrome, neurotoxicity or immune effector cell-associated neurotoxicity syndrome. Infections would happen as well. Sometimes there is intense inflammation from cytokine release syndrome that can cause what we refer to as hemophagocytic syndrome or macrophage activation syndrome, which is basically a bone marrow failure state that typically is a dangerous situation that carries high mortality. Thankfully, that doesn't happen very often. Close monitoring is needed during those initial 4 weeks for that reason. Some programs have very good setup, including being able to see patients on the weekend in a clinic setting. So as an alternative, patient could get the infusion and go home. They would have a quick access to a provider through a phone, and they are seen daily for 2 weeks, including through the weekend. There are some centers that employ remote monitoring technologies, which is like a patch that's put on the skin that can record fever. There's a lot of interest now in utilizing things like devices like Apple Watches or whatnot, or similar kind of things that already capture the patient pulse and things like that. There's just a lot of interest and activity in that space, but nothing has been validated so far to make a recommendation. But many centers are using those remote monitoring technologies. Cytokine release syndrome happens because of the rapid suppression of expansion of T cells. So if the patient has a lot of lymphoma, typically they have a higher risk of having more cytokine release, because the T cells, when they go in, they see just a lot of malignant cell and they expand way more. And with their expansion, they produce what we call cytokines, which are markers of inflammation. And some products seem to be more toxic than others in that regard. Patients typically would have fever, low blood pressure, and shortness of breath. it is an FDA requirement that any patient who have a card that receives CAR-T are given a wallet card. That wallet card they keep in their wallet, and whenever they go into an emergency room, they show them that card. It would have typically a number to gain quick access to the CAR-T center and get some further guidance. The easiest way to understand cytokine release syndrome, it resembles a bad case of the flu or COVID-19. And one thing you might find interesting that we treat cytokine release syndrome with steroid and tocilizumab. Tocilizumab is an anti-interleukin-6 antibody, and interleukin-6 appears to be the main mediator of cytokine release syndrome. So during the early time of the pandemic, tocilizumab had also been employed in the treatment of acute COVID-19 infection. So there is some similarity between the cytokine storm that happened with acute COVID-19 and with cytokine release after CAR-T. Severe cases will need to be monitored and managed in the ICU. Neurotoxicity is also known as ICANS, and this happened because of cytokines, the same inflammatory molecules like interleukin-6 and other, crossing the blood-brain barrier. That's a layer of cells that protects the brain from the bloodstream. But with inflammation, that blood-brain barrier will open, and those cytokines will gain access to the central nervous system, spinal fluid, and cause a lot of inflammation there. Patient will typically present with tremor, forgetfulness, difficulty comprehension, confusion. Sometimes they can have a seizure. It can look like a stroke. As you are in the hospital or an outpatient getting CAR-T, you're going to get frequent standardized assessment. I'll show you the kind of question that you'll be asked in a minute. Sometimes that question might seem silly that you're being asked the same question every day, but that's purposeful just to make sure we can detect that problem early. It is rare that neurotoxicity will happen without a preceding cytokine release syndrome. Usually patients start with having fevers and tachycardia, and then they evolve into having a neurotoxicity, but that's not absolutely necessary. There have been cases where neurotoxicity could happen without a pre-existing cytokine release syndrome. It's more common with certain CAR-T products than others. It's typically treated with high dose of steroid. Most cases are reversible, thankfully, but some would be monitored in the ICU. Unfortunately, part of the challenge, especially with elderly patients, they will get so sick, and even after the inflammation resides, they become quite deconditioned, and they may end up needing something like a skilled facility stay, just because from the intensity of central nervous system inflammation. This is the typical neurologic assessment, what we refer to as the I-score. If you went through that process, you would know what that involves. They will typically ask about what year, what months, where are you, what's the hospital you're in, what city. They will ask you to name 3 objects. They will ask you to follow simple commands like, stick out your tongue. They will ask you to write, and then they would ask you to count backward. And all of that have been validated to detect early signs of neurotoxicity. This is a typical patient as he went through neurotoxicity. We frequently have the patient write every day, whichever may be in this situation, something where they are, they're down. And as you see here, how as the patient went through neurotoxicity, how their handwriting became more scrambled and how it sort of reverted back to normal as they recovered. Shifting gear, we're going to talking about delayed toxicities that happen about 30 days after the CAR-T cells have been administered. One of them is the long-term loss of B cells, because with all of the currently approved CAR-T product in lymphoma, they target the same antigen, which is CD19. That same antigen is present on both malignant and normal B cells. And some patients would experience long-term loss of B cells. What we have been learning lately that there are some patients who recover T cells, who recover some of their B cells. I don't believe we have accurate statistics about the incidence of such. It typically takes at least 2 years before that happens, and your doctor can measure the B cells in the blood by flow cytometry. Also, they would measure the immunoglobulin level as the patient starts recovering B cells. They will be able to make their own immunoglobulin, but some patients will need to remain on intravenous immunoglobulin infusion long term, unfortunately. Some patients would experience low blood counts, neutropenia, would need drugs like filgrastim, and sometimes that can be challenging if there is not enough, if there is, because of insurance reasons, patient would need to be on long-term antivirals, prophylaxis for pneumocystis as well. Patient would need to have repeat vaccinations. Patient who has had COVID-19 vaccinations, they need to be repeated. There is some increased risk of non-melanoma skin cancer, like squamous cell carcinoma. There is increased risk of having myelodysplastic syndrome or acute myeloid leukemia. And some patients would experience what we call brain fog, which is basically a lingering form of neurotoxicities that we're still trying to further define. This is a list of all of the currently available CAR-T products in both lymphoma and myeloma and their indication. I'm not going to go through that, but that will be in your handout as you choose to download it from the site. And I thought this would be a very helpful thing to show to you. This is a survival curve. This is not the same trial. These are survival curve from 2 trials that have been superimposed from each other. One of them, which you see in the bottom in red, this called the Scholar 1 cohort, which is basically a cohort of patients with aggressive B-cell lymphoma before the introduction of CAR-T. And you are looking into an overall survival of 4 months. And the top curve is from the clinical trial ZUMA-1 that led to the approval of Yescarta. And you just to show to you that in a similar patient population separated in time, the overall survival has improved from 4 months to 24 months. So about 50% of patients could be cured with CAR-T therapy compared to 12% of historic control. So this is just to give you a visual about how much positive impact the CAR-Ts have had in this space. And to finish up, this is sort of gives you a snapshot of the different products approved in lymphoma and their indication, and the response rate and the survival, but also the toxicity, the incidence of cytokine release and neurotoxicity or ICANS. I'm not going to walk you through all of that, but I kind of want you to appreciate, if you look at the median survival at 1 year, you're looking at number from 60 to like 80 or 90%. Pretty impressive number compared to the 12% numbers that we have seen earlier in the Scholar 1 cohort. So really big, huge difference. But also if you move your attention to the last 2 columns and you look at the cytokine release and the ICANS, you're going to see that some products appear to be more toxic than others. And certainly as you meet your doctor in the CAR-T center and talk to him or her, he'll be able to recommend to you what would be the best product that will fit your specific needs. So trying to move to the next slide. Yep, here we go. Thank you for your attention. This is just a snapshot of my center at OhioHealth and the wonderful team of people I work with. As you realize, it takes a whole village to administer those complicated treatment and prepare for patients. We have folks who collect the cells from pheresis. We have folks in the lab who store the cells and ship them to the company. We have nurse practitioners and nurses who take care of the patient in clinic and on the outpatient floor. We have administrators and other supportive personnel who work with things like insurance authorization, making sure all of the medication are approved. Sometimes we need to establish a single case contract for a particular patient who doesn't happen to have approval to receive therapy at our center. So it really takes a whole village of people just beyond the physician and him or herself to get those therapies to you. Again, I'm grateful that I got the opportunity to speak with you today, and I'll gladly answer any questions you have.
Thank you, Dr. William, for this excellent presentation. We will now begin the question and answer session. If you have a question for Dr. William, please use the chat box on the lower left side of your screen to type in your question. We will answer as many questions as possible. Our first question is, when is a CAR T cell therapy treatment considered successful? When do you, doctor, know whether or not CAR T has cured a person?
Oh, that's a great question. I believe that if the patient is in remission for 1 year after receiving the CAR T therapy, they have a very high incidence of being actually cured. There is a small chance of that they would relapse later, but what we have seen from many of the big trials that led to the approval of those patients, and as well as from our cumulative individual experience and also registry studies, that patients who are in remission for 1 year after they receive the cell tend to remain in remission.
Okay, I think this is a question from your slide regarding collecting CAR T cell therapy cells. Is one viral vector more effective for lymphoma patients considering CAR T cell therapy? And then could you please explain to the audience a viral vector and the transferring of cells?
Sure. So the viral vector that's typically used now for all of the commercially approved agents is a lenti or a retrovirus. That's an inactivated virus from the HIV virus family. It's not HIV. Certainly, I'm not going to give the patient HIV, just an HIV-like inactivated virus. And those viruses are very potent in inserting genetic material inside lymphocytes. And it's not the virus that made one cell more active than the other. It's actually the structure of the genetic construct. So the genetic construct will include a piece that will make the cell recognize the antigen on the surface of cancer cell. That's typically a part of the immunoglobulin molecule. But also there is a T cell co-stimulator, and that would make the cell grow and expand. And there is the T cell co-stimulator piece is what varies from one product to the other. And that's why it appears that some products may be more effective than others and potentially more toxic. Something to note that those products had not been evaluated head-to-head. Many of the experts in the field believe that after about 1 year, pretty much most of those agents are comparable for the big part, but it is that T cell co-stimulator piece that's introduced that would make more products seem to be at least more active earlier, but sometimes that comes as a cost of increased toxicity as well.
Okay. For follicular lymphoma, is initial chemotherapy followed by relapse and autologous transplant considered 2 lines of therapy?
Yes.
Okay. Can CAR T cause pituitary problems?
Not directly, not to my knowledge, but what could happen is if the patient develops a severe cytokine release syndrome and develop like circulatory collapse and shock, and they drop their blood pressure significantly or develop macrophage activation syndrome, they're sick, they're in the ICU, they are on stressor medication to raise their blood pressure. Sometimes that would cut the blood supply to the pituitary gland, or if they have sustained sepsis from a severe infection, then that would lead to a damage to the pituitary gland. But that could happen with any sepsis or with any infections, not particularly unique to CAR T.
You mentioned CAR T cell therapy is used for patients with mantle cell lymphoma. Is it also an option for geriatric patients?
Yes, I believe there is no age limit. And in my prior institution at OSU, I have treated an 80-year-old patient with CAR T, and he did really well. I believe now, and that's true for transplant and CAR T, we don't look at age as a number. We look more at the fitness of the individuals. There are 80 and sometimes 90 years old who walk and cycle and exercise, and there might be a 40 or a 50 years old who is like their health is so impaired to be able to get anything safely. So we don't look at age anymore. We look more at functional status. Sometimes, depending on the patient insurance or other things, they might be denied certain treatment based on age. And in that situation, the clinician can try appeal to you. They may or may not be successful.
Which vaccines do you recommend after CAR T cell therapy when a patient was revaccinated just a few years earlier after an autologous stem cell transplant?
I don't we have a lot of, evidence to guide us. Programs have different sort of approaches to that. There is no unified consensus. But there are multiple options. I mean, you could revaccinate again, and there is absolutely no harm in doing that. Some centers, they also measure the titers. So they could measure, okay, do you have enough measles or mumps or rubella or whatever immunoglobulin level in your blood. And these are high enough to protect you, then you don't need to be revaccinated. One word of caution is your doctor would have to order the right test. So if they just order mumps IgG without a number, and it will come back as positive, that's not going to help you much. What's required is a titer, and there are certain validated titer numbers that would say that you have a protective immunity. So that could be the other option compared to revaccination. Not all clinical laboratories run those tests, but certainly there are some reference laboratories that run those tests, and that would be an alternative to revaccination.
Can you talk briefly about full functionality and recovery with regards to quality of life after CAR T cell therapy?
Extremely variable. It really depends on how severe of a toxicity the patient would have developed. So if the patient develops severe neurotoxicity, they are in the ICU, they had a seizure, and especially if they're older, their quality of life may be impaired for a very long time. There are certain factors that would predict such a thing though. So some centers, they went into a developing geriatric clinic, and they perform what they call a complete geriatric assessment, which is like a day-long assessment of questioning cognitive assessment, physical therapy. There are some validated simpler methods. My most favorite method I use is the get up and go. So I have a patient in my clinic. They're sitting on a chair, and then I ask them, okay, get up and go to the door, open the door, and walk out. And I observe how quickly does it take them to get up from a chair and go out. This get up and go test have been validated in how healthy the person is. I use that frequently. It takes 5 seconds, and it's a very useful test. And the other factor in the equation is how much tumor they have. If the individual is loaded with tumor and you give CAR T, you know upfront that you have a higher risk of cytokine release and neurotoxicity. Sometimes that pre-medicates those patients with steroids or tocilizumab. There is data suggesting that that doesn't impair the response to the CAR T and might be protective at toxicity. So there's a lot we can do in making sure we select the best patient for therapy and also to try to prevent those toxicities upfront. But it's not always as easily predictable. The other factor is some CAR T agents are more toxic than others, and your clinician will be able to guide you which is the right product for you. Generally, if I have a borderline patient, I wouldn't give them the most toxic product because I know if they develop neurotoxicity, they may not survive or they might be very impaired. So all of those factors, your doctor will be able to guide you going through what would be the right product for you.
Is CAR T cell therapy used for small B-cell lymphoma?
Yes. So small B-cell lymphoma, there is one product that has been recently approved for CLL, which is lysocell. So small cell lymphoma is the tissue equivalent of CLL. So I think if it is submitted as CLL, it will be approved in that regard. This is just something that came on in the past months or so.
Okay. This patient had their own stem cells collected for their autologous transplant, and some remain in frozen storage. They would like to use these to boost their system, either before or after CAR T procedure. Is that possible or even advisable?
I wouldn't advise it, but it's a great advantage that you have those, because if you haven't received CAR T yet and you happen to have developed a severe toxicity and your count wouldn't come up, those cells would come as a lifesaver. So it's great you have those. I don't recommend that you use them if you don't run into any trouble. They might come handy to you in the future. Let's say, if God forbid you get CAR T and you relapse, and maybe your doctor would do an allo transplant on you, and then after that you have problem recovering counts, your own cells from the past can come to rescue. So I don't recommend you use those just to boost if you're doing fine. But this will become a very handy tool for your doctor to save you should you develop a severe complication from the CAR T.
Okay. This person's husband is 77 years old and has diffuse large B-cell lymphoma. He's 3 months post-CAR T-cell therapy using Yescarta. How many people get B-cell aphasia after CAR T, and is there any hope for those B cells returning? And if so, when?
There is hope for those B cells returning. Most of them, they don't return before 1 to 2 years. They typically do not return that early. Actually, you don't want them to return that early. Usually, if you start seeing them returning that early, it means that whatever is returning is really the cancer cell. So there's some hope for recovery. I don't believe we have accurate statistics yet because we don't have very good validated methods of measuring these cells in the blood. But many centers are able to do flow cytometry in the blood, but most recovery will take at least 2 years time.
And then
but the other thing is, right, sorry, I want to just also elaborate. If B-cell recovery doesn't happen, it's really not the end of the world. I mean, as long as the patient's able to get intravenous immunoglobulin, they're usually protected. We make that, kind of joke in the transplant cell therapy world. We say these cells are dispensable. You can throw them away. That's why we have a challenge in trying to develop CAR T for T-cell lymphomas, because T-cells are not indispensable. If you get rid of all T-cells, the patient will not survive. But B-cells, you can live long-term, a healthy life without B-cells, as long as you have access to intravenous immunoglobulin.
So the follow-up, is age a consideration?
It likely is, but I don't think we have an evidence validated answer to that. I think what's more likely a consideration is the number and the intensity of prior therapy. So whichever the patient has been exposed to previously, going to be a major factor in their ability to recover B-cell. For instance, if they have had autologous transplant before getting CAR T, it is probably less likely that they will recover B-cells.
Okay. Can you comment on why a 24/7 caregiver is required, and what does that caregiver need to do or need to know about the CAR T-cell therapy treatment and their role in assisting the patient?
I think the challenge is if those patients can get sick very quickly in a very unpredictable way. So let's say if the patient is in their home or they're staying in a hotel because they live in a rural community and they need to stay within a close proximity of the treatment center, they can get sick very quickly and just collapse in their home or in their hotel with nobody knowing. Now, would that change if we have access to remote monitoring? Maybe. But the problem is, let's say, just for argument's sake, we have a remote monitoring platform. Who's going to sit on that platform and monitor patients 24 hours? If the patient removes the patch from their head, maybe they'll have a sweat and the patch will fall off. Or maybe I'm seeing the patient have tachycardia and I try to call them and they don't answer. What I'm going to do? Then you have to maybe call the law enforcement to come and check with them. It just creates a lot of logistical problems. I would say, in summary, the rationale behind that patient can get unpredictably very sick within a very short period of time that they may not have time to call for help themselves. What that caregiver needs to know, they need to be educated about what to watch for: fevers, shortness of breath, dizziness, or confusion, things like that. It's very simple. They don't need a lot of education. You just need to be committed and be there all the time and know when and how to call for help.
Okay, what are some options for aggressive lymphoma patients if CAR T-cell therapy fails?
There is quite a bit. I mean, there are clinical trials, and we encourage patients, all who have failed after CAR T, to go on a clinical trial. Sometimes, depending on the length of remission after CAR T, a second CAR T infusion might be also tried if the company still has cells and they're willing to do so. There are other agents that could be given after CAR T that have not been tried before. And if the patient can enter a remission with any agent or have their disease controlled enough and they're healthy enough, they can undergo an allogeneic transplant as well. I have done that successfully in a handful of patients.
Okay. How long does it take for low blood counts to recover after CAR T-cell therapy?
Great question. Very variable. Some patients might take months, some will take years. Some of them, they may not fully recover. And I don't think we have a great way of predicting such. It's a hot area for research, and we're still learning what to do. I want to caution, though, that the person doesn't need to have a completely normal, pristine blood counts to be alive and healthy. Some patients would walk around with low blood counts, they have no infections, they're healthy, and they're doing fine. So I wouldn't agonize about that abnormal blood count unless it's severe enough or if it's causing significant problems.
Thank you. Well, on behalf of BMT InfoNet and our partners, I want to thank Dr. Willen for a very helpful presentation. And I also wanted to mention to the audience that BMT InfoNet offers a great resource. We have a database for medical centers that provide CAR T-cell therapy, and you can access that database by going to bmtinfonet.org. Thank you, audience, for your excellent questions. Please contact BMT InfoNet if we can help you, and enjoy the rest of the symposium.